again. Can you celebrate our panelists in the chat section by putting some hearts in the chat section? Did they not give it up? Valerie Spencer talked about nuts. Cecilia talked about stop telling everybody you a sex worker. And Jenna said the systems are not set up for us. But she talked about where we started at and where we are at now. So we have made progress. I am so excited to be hosting you amazing people. I hope everybody had a wonderful time getting their breaks, getting something to drink. Again, we want to celebrate all of our wonderful panelists. Sean, the ecological perspective for deconstructing medical mistrust in trans health. It was absolutely amazing. So welcome back, everybody, from break. I hope you all had a good stretch, grabbed a snack and some water, and are breathing hard like me because you ran up a ton of steps. Can we celebrate exercise for today? So listen, I am pleased now to introduce Andrew Miller, MA-LPCC, whose pronouns are he, him, his, and L. Andrew is the LGBTQ health educator trainer for Denver Health and Hospital Authority. Andrew is a phenomenal trainer with years of experience working with health systems to make them more affirming and safer. I haven't heard that word in a long time in narrative, safer. So I'm excited to hear Andrew tell us what safe means for transgender persons. Andrew's presentation's consideration for building affirming care systems will walk you through the steps needed to develop an affirming care system. Get your pens out, get your papers out, get your hands out in our chat section, and please help me welcome Andrew Miller to the stage.
Hi, everybody. Thank you so much for that very warm welcome, Marissa. I am not out of breath from walking up the stairs, but am out of breath from being so nervous. Again, my name is Andrew Miller. I actually use he and they pronouns. I work for Denver Health's LGBTQ Health Services Department as our LGBTQ health education trainer. I am so excited to be here with you all today. And before we move forward, can we just give a huge shout out to everyone who has planned this summit, to everyone who has spoken so far, and that mind-blowing panel that we just sat through. Jenna, Valerie, Cecilia, that was, in all of my years doing that, that was so moving and impactful. And I will remember that for a long time. And also, boy, did that hit the imposter syndrome right there for me. So what I'm gonna do now is share my screen, and we're gonna kind of spend the next a little bit over an hour together talking about what is an affirming system. The panels and conversations we've had so far have talked about some of these things. Or how do forms impact us? What do policies look like? And so what I want to do is kind of break down some of these large topics and give a few examples of what these might look like in your health system. What I do ask for is for us to remember that we have so many different experiences here on the line with us today. Some of us have lived personal experiences as trans people and non-binary people, navigating health systems, working in health systems. And for some of us, we've been building these health systems for years and years and years. For other of us, this might be brand new information. So I really hope that we can utilize that chat function and share your experiences, your thoughts, how your system is doing it, and questions that you might have as we go through this. All right, now I'm going to do the most technically difficult thing of this and share my screen. Could I get a thumbs up from someone on the screen? Marissa, if you can see my screen correctly.
Looks good, Andrew.
Awesome, great. Let me pull up our chat. Perfect. What I will say, oh, there we go. Sorry, I was having trouble seeing our chat there. Great. So our objectives today are to define some of the terminology we use within gender affirming healthcare, to describe a few different components of what this affirming healthcare system looks like. And also we're going to talk a little bit about how we can evaluate the systems that we're currently in. One of the things you will be provided with after this presentation is we have a whole packet called Building Affirming Health Systems. And so this goes through each of the topics that we're going to talk about today to kind of pull out and break down what are each of these terms. in that packet, we also have created an evaluation system that kind of lets you get started on looking at what's working and what's not working when it comes to affirming care, and what are some of your start spaces. So what we're here to discuss today is affirming systems. And so first off, before we get into it, if you could just enter into the chat box for me, what does it mean for a system to be affirming? Let me know what that means for you and your system. What does it mean for a system to be affirming? We have Leo said to take you as you are, to be informed, comfortable, supportive, accepting of every person's, that people are validated for who they are. We have folks saying that everyone in the system is called by the right name and pronouns, that everyone is welcome and accepted for their authentic selves, non-judgmental with partners and patients, allowing someone to be themselves, respectfully addressing as such. Oh, these are great. Systems that have you in mind and in line with who you are as the person you know you are. Oh, great. To not be treated as a spectacle or extraordinary or brave, yes, and just another human being. Not questioning one's existence. Yes, exactly. In healthcare right now, we've been using this term affirming care or gender affirming care without really actually ever defining it, and without asking trans and non-binary communities to be centered in that definition. And I love that this is what we're pulling, that it's more than just a name and pronoun. It is the overall acceptance of who someone is as their authentic self. So yes, and as Valerie said, they don't over trans me, that my trans identity isn't everything, but it's a major part of who I am in the care I'm receiving. So for today, what we're gonna do is kind of break down affirming care into a few different topics. First of all, the definition I use for affirming care is, at its core, it's supporting someone for who they know they are as an individual living their authentic selves. And so when we're talking about healthcare, we need to think about all of the ways that someone can be affirmed or disaffirmed throughout their journey with us. So what we're going to do is first break down language and terminology. Then we're going to move into documentation. So intake forms, EMRs, what does that look like? How are we using them? How are they harming patients or helping patients? Next, we're going to talk a little bit about the clinical environment. So what are the things that are in the physical space that help affirm identities, help affirm our patients? Then we're going to talk about policies. Policies are so important, and in policies, we're going to break it down between policies as well as talking a little bit about billing and revenue, what that looks like. And then we're going to talk about training. So often healthcare orgs will say, yep, we've had a pronoun training and we're good to go, but we know those aren't effective. This has to be continuous. So we're going to break down these topics and look a little bit more into detail. So I know that for a majority of us, these are very familiar terms that we have done a million times. And so what I want to do, just to make sure we are all using them in a similar way as we navigate this, is we're going to have Misty launch a few polls for us so we can see where we're at. So Misty, could you launch the first poll for us? All right, this poll says, true or false? Sexual orientation is based solely on who someone wants to have sex with.
All right, Andrew, it looks like we have almost 50% have participated.
Great. Can you, awesome. All right, Misty, would you tell me those poll results when you get them?
And the poll results are posted.
Perfect. So false, sexual orientation is not based solely on who someone wants to have sex with. What we know about sexual orientation is it's a lot of different things. It's about attraction, but attraction can be romantic, psychological, emotional. It can be sexual, but that's more than what it is. We recognize that what attraction and orientation looks like for one person is not going to be the same for someone else. Another important thing to know is we recognize there are over 100 different sexual orientation terms and more language is being created all the time. We are lucky that we live in a time that folks are creating language to help explain and define their experience. We all deserve to have words that help us feel at home in who we are. All right, will you launch poll number 2, Misty? All right, sex assigned at birth. This is the determination of a person's sex based off of A, hormones and chromosomes, B, the visual appearance of genitals at birth, C, a blood test at birth, or D, none of the above.
So far, almost 30% have participated.
All right, let's keep those clicks going.
I will close the poll at 60%, okay?
All right. Come on, y'all, we got it. Great. Yep, that answer is B. Sex assigned at birth is the determination of a person's sex based off of the visual appearance of genitals at birth. Sex assigned at birth is a socially constructed term. We recognize there is so much more than male and female, and oftentimes intersex communities are completely erased in our conversations. And we know that sex assigned at birth is a term that is often collected in healthcare settings, and we'll get more into that next. All right, will you launch poll number 3, Misty? True or false, gender identity is a person's deep-seated internal sense of who they are as a gendered being, specifically the gender in which they identify themselves as. Is that true or false, folks?
This one is coming in quick. We are almost to 50%.
There we go.
All right, I am going to post the results.
Great, A, true. We know gender identity is someone's internal understanding of who they are as a gendered being. And the thing about all of these terms is we all have our own definitions of what these mean. A definition in itself is very limited in what this can be, but generally the definition we're giving is someone's internal understanding of who they are as a gendered person. We recognize for some people their sex assigned at birth and gender identity might align, and for some people that might not. All right, final poll there, Misty. Great. Gender expression is a social construct in the way we express our gender. This may include which of the following: hairstyle, clothing, mannerisms, makeup, or all of the above?
We are reaching 50%.
There we go.
And rising. I'm going to post the results.
Perfect. All of the above. Gender expression is a social construct. And what we know about this construct is it's demographically and culturally bound. What it means to quote unquote be or look masculine in one area or one culture does not necessarily mean the same thing somewhere else. But what we do know is we as a society place a lot of value into that gender expression. Let's think about all the times in healthcare that if we see someone who has short hair and is wearing a quote unquote masculine shirt, how often is that person getting called sir? No matter what their identity is. We don't know someone's identity based off of someone's external visual cues, but we do like to make a lot of assumptions about someone in that. All right, thank you for reviewing that terminology with me. We're going to use these terms moving through this training, so I wanted to make sure we all were on the same page for that. And I think it's really important that we also talk about how the term transgender is a colonized term as itself. Though the term transgender is often used as a broad and universaling identity category, the term's Western origin and logic prevents it from accurately representing the gender diversity that exists around the world. Many of the terms listed on the screen have ambiguous or multiple definitions that intersect with other gender identities or sexual orientations. And these can depend on a person's interpretation, cultural background, or location. Some terms are linked to specific regions or cultures, but they may also extend across national borders or may not be limited to the countries listed. A single term may exist in multiple dialects and languages, or may bear different meanings within a single language. And one of the reasons I think this is so important to say is oftentimes when we're in healthcare, we talk about these intake forms or EMRs and what information we can use, and we categorize all trans and non-binary people with one term. But the term we call ourselves, the identity we know that is true for us, holds value. And someone being able to identify themselves using the language that is home to them is important. And so making sure we have options for folks to be able to know that. And when we're talking training in a little bit, making sure that we're going beyond the 101 of just defining transgender, cisgender, and non-binary, but going into the broad category of identity language. All right. So now what we're going to do is look at language and documentation. Y'all, I've been training nationally on LGBTQ care for about 10 years now. And oftentimes we think of things like forms and EMRs as really small things, but they make a huge impact on our patients. So one of the things I'd like to do right now is, Misty, you can launch that poll we have for this one. And my question is, what information is your program currently collecting on the forms within your health system? So within your organization, what information is currently being collected on your forms or within your EHR?
We are currently at 20%.
I see in the chats, I was told I'd be a good game show host. So let's keep using that mentality and fill in those answers. I want to know what information your system is currently collecting.
We are currently sitting at 45%.
Let's get that to 50. Come on, folks, we got it. Perfect. So I love this because we have so many folks from different organizations on, and I love that we can actually see what we have. So in over 93% of respondents, folks are collecting name. We have 80% of folks collecting legal name. We see that 68% of folks are collecting pronouns. We see that jumping down, we have 94% of people collecting race. We see written and spoken languages at 74%. What we know about this demographic information is that there is so much information we could collect, but it's really important that we start to differentiate what information do we need to collect and what information shouldn't we collect. So one of the things that I like to talk about in this is many of us have certain information that is required to be collected. In addition, depending on what services you're offering, some of the items on this slide might be relevant or some might not be. There are many reasons you may wish to collect things like sex assigned at birth or gender identity on an intake form. However, before adding these fields to your questionnaire intake forms, it's important to evaluate, why are you collecting that data? Is this data necessary for patient care? Are you required to collect this data or report this data? When these fields are not being used to improve patient care, or when there's no intention or necessity to meaningfully report the data, you might consider not having them. For example, it depends on the service you're offering on whether you need to collect name or legal name, or maybe both. And again, you'll hear I'm not saying the term preferred name or preferred pronouns because it's not a preference and it's not an option. I have the name I want you to call me, the name that I must be called, as well as the name that was legally given to me or the name that I legally have. If your system is not required to report legal name, then why make folks put it down? We need to make sure that we're being very clear of what information is required and not. Things like pronouns we should be collecting on every single form. Oftentimes I'll only see it on an intake form, but the more that we can have pronouns listed on the forms that our patients and staff are filling out, the more that we are able to actually normalize this and make sure that we are giving folks the opportunity to disclose their pronouns, and then we have to make sure we're training staff to use them. Things like gender identity, sexual orientation, race and ethnicity, and language are important aspects to be collected, because if not, specific healthcare needs cannot be identified, the health disparities communities experience cannot be addressed, and the important healthcare services may not be delivered. It's also an important part of affirming someone's identity and understanding the language they may use to describe their identities. And we'll get more into detail with this in the next few slides. And then the last thing we have on here is sex assigned at birth and legal gender marker. Again, it's important that we negotiate when is this information important or not. For places like mental health facilities, oftentimes having someone sex assigned at birth is not necessary for the clinical care you're providing. If it's not clinically necessary or you don't have to report that data, we shouldn't be listing it or making folks fill that in. Oh, I see a comment about how confusing that EHR can be. Yep. And we're going to pull that up next because oftentimes the language we can put on an intake form might be completely different than what information our EHR can actually host. And we'll talk about some workarounds for that too. So next, I briefly wanted to write out a few identities that can kind of fall within the topics we're talking about. As a trans person myself, oftentimes I'll go to a healthcare facility, go to fill out the intake paperwork, and under gender identity, it'll say male or female. For myself as a trans person in that moment, I feel unsafe, I feel unwelcome, I feel like my healthcare needs can't be met here because if I can't identify myself, how am I going to be cared for? Are you asking me actually my sex assigned at birth? Do you want to know my gender identity? We need to make sure that when we're asking these questions, that we have a wide variety of options using affirming language that can actually be used by community. The other big thing about when we're asking this information is making sure we have write-in options. For example, for pronouns, we have a list of pronouns, including just using someone's name. And then, instead of including an option that just says other, we can have an option that just says write-in. And that needs to be able to collect the information that someone is using, the term someone is using. We could also have that listed as option not listed. And then when clicked, that should give folks an ability to write in those identities that they hold. And again, and this was said yesterday and a bit today, is we need to think when we're talking about gender identity, what is the language we're using? We're moving away from terms like male to female or female to male, these very sex assigned at birth based terms that are not focused on someone's identity of who they know we are. And so we need to start really pushing our systems to change that language to make sure the language that we are using and posting is affirming in that. And this has a little bit more information, again, breaking down sex assigned at birth and legal gender marker and sexual orientation. One of the big things I've run into recently with legal gender markers, we recognize in a few different states, we are able to put X on a legal gender marker. So on a Colorado ID, you could add M, F, or X. We're moving forward also with passports, if folks are able to access those, able to have X on that. That means your healthcare system needs to be able to collect that information. We're dealing with that here at Denver Health. What happens if we have a patient come in and they hand us their ID and it says X on it and our EHR only gives the option of male or female? What do we do? Again, we need to make sure part of this building and affirming system is making sure we are constantly doing that quality improvement to follow the path of what communities are needing and wanting, including documentation terms. Another thing I will say for legal gender marker is, again, this is one of those points that we have to figure out, is this necessary for your system or not? If you are not required to report that data or don't collect health insurance, you might not need to collect legal gender marker. But for myself who works at a federal hospital system, we have to have that legal gender marker because that's what aligns with the health insurance marker. And so making sure we have alignment and are listing these categories are vitally important for, again, using these paper forms or electronic forms to flag to folks, your identity is important here and we want to ask you about it. And we'll get into how we ask about that next. All right, so next up we have where and how this information can be collected. There is no right or wrong way to collect this type of information. Oftentimes, what I found in healthcare settings, we refer to demographic collection information for LGBT communities as SOGI data. So sexual orientation and gender identity data. It was pushed down a few years ago from Joint Commission and HRSA to include SOGI data, which is sexual orientation, gender identity, sex assigned at birth, and pronouns into regular demographic collected information. Here's the thing about that. I will go back on what I just said. There is a right or wrong way to do this. This has to be done confidentially. So we are not asking folks identity questions when they walk up to a public space like a clerical desk. This is only being done when it's in a confidential setting. The other thing about confidentiality is we need to make sure that that is clear for folks before these questions are asked and before they get answers. So one of the ways that folks can fill out forms is by doing this at home. So what forms do you have listed online that folks could fill out? They're intake forms. Before someone even fills that out, there needs to be a blurb saying how this is confidential, where this information is going to go, who has access to this, especially when we're working with folks who are undocumented and especially when we're working with folks who are minors. It's important that we make this very, very clear before folks are actually asked these questions. So again, this could be done at home. This could be done when folks arrive into your physical setting. This could be done on paper forms, or this could be done on a tablet. Another place this could be done is once someone is roomed. So at Denver Health, we have our MAs and CNAs ask our SOGI data collection questions once folks are in a room when they're doing a general health history. So again, not making it just ask this to trans folks, but actually making it so this is across the board. This is asked to all patients who enter your system, and it's asked to patients in the exact same way. So again, this could be done by that MA-CNA in a health history, or it might be done by a provider doing input. And I'll show you what that form looks like next. I see some comments in the chat. The gender marker collection can be really frustrating for trans people trying to understand lab values. Yes, especially when labs are uploaded to a patient portal before a clinician has a chance to review them. I could not agree more. And this is one of those things about forms that we don't think about, or EHRs that we don't think about. We need to be sure that when an item is being pulled and placed on a lab, is that gender marker sex assigned at birth? Is that someone's gender identity, or is that their legal gender marker? And not only does this need to be clear to every single person who works in that health system, this also needs to be clear to the patients. When patients' identity information is going to be put anywhere, if they're going to see it, they need to know ahead of time. If someone's legal name is going to appear on a pharmacy label, we don't want them to discover that. We want to give folks that heads up, as well as be advocating to be changing the system to make sure that someone's name is placed, not legal name. All right, and then up next, I just wanted to show a few examples of forms. Obviously, I work for Denver Health, so I pulled our form. One of the things that I love about forms is, when possible, just make it a write-in. I know oftentimes we have to box things into categories, and I'll show that next. But when possible, we want to give folks the ability to use their language and their words to share the identities that they hold. So this is just one example of how that might look. And again, we also want to explain why we are gathering this information, explain to folks what we're doing, and before folks even fill it out, explaining what is the confidentiality around this. So transgender and non-binary healthcare relies on policy to reflect the changes that you're making to create an affirming system. When we don't have policy in place, systems tend to go by a case-by-case basis that leaves far too much room for bias and discrimination. You need to look at your system and figure out what are the ways folks are accessing care, and what are the ways we can create policy to support equitable and just care that centers the trans and non-binary community, not the cis community around that. So when we're talking about just our staff, the folks we want to hire, that we want to bring in, what does your equal employment statement say? Does it include things, not just gender identity, but gender expression? Do you have plans written out and policies written out of how to support trans and non-binary people in the workplace? Whether this is folks coming out to staff, whether this is folks coming out using different pronouns, how can folks actually be able to utilize the health insurance that they're provided from their health system? Does your health insurance that you offer to employees cover things like gender affirming hormones and gender affirming surgeries, if this is services folks are looking for? Again, we want to make sure that we are working and sharing the space, not sharing the space, creating the space for our trans and non-binary employees to be able to work with us and not just be the tokens or the checkboxes, but actually be cared for and built as leaders. Then we get into some of our access for patient care. So non-discrimination policy, again, making sure that we are listing multiple identities in there, including gender identity and gender expression. And then let's get detailed with things like patient bill of rights. Generally, what I find is folks will put wording in there that says things like patients will be respected and not discriminated against. Well, what does that mean? I want to make sure that in patient bill of rights, it is listed that patients will be called by the name and pronouns that they go by, period. Because again, when I'm mispronounced or I'm misnamed entering a hospital system, what are my rights? Who do I go to? What is the repercussion or what is the result when someone purposely misnames me over and over and over again? If it is my right to access care, then I want to be called the right name and pronouns. These things need to be listed in Bill of Rights. And then let's talk about accessing services. So for folks to access things like hormone therapies, what are your system's requirements? Do you follow WPATH standards or is this your own healthcare system? Do you provide hormone therapy based off of informed consent? And again, we want to write a policy that documents very clearly what this is and what this stands for. Same with gender affirming surgeries. What are your requirements? How do folks access this? Do you have requirements like BMI restrictions, like hormone therapy? Are those yours or are those health insurance systems? If they're yours, write it down, make it clear. Let folks actually see what needs to be done to access a service in your hospital system. And then when we have things like behavioral health letters, as a former therapist, the behavioral health letters drive me up the wall. I think oftentimes a majority of these are used as gatekeeping and restrictive, especially from health insurance companies. If you provide behavioral health services, create a policy that shows how many sessions it takes to write a letter. This should be generally no more than 1 or 2 sessions. If you're able to provide behavioral health letters at no cost, please do that. Folks are dying not able to get these services, to get a letter that allows them to consent for their own body. So again, make it very clear what is needed to write a behavioral health letter. Make that clear and accessible for folks to do. Same with restrooms. What's your restroom policy? Do you have gender neutral restrooms or do you only have gendered restrooms? If you only have gendered restrooms, are you using, do you have a policy that says that folks can use their restroom based off of gender identity or gender expression? What is your wording there? Rooming policies. Rooming policies, especially if you work in any spaces that do inpatient services, is absolutely necessary to have put in place. Oftentimes what we see happening across the US is a trans person goes into services for substance use, enters the hospital system, and they are placed, or inpatient psych spaces, and they are placed in a room by themselves and given no option. Isolating trans people does not care for trans people. It does not affirm trans and non-binary people. It hurts and harms trans and non-binary people. Look at what rooming policy you can write. What are the options folks are given? And again, we want to have this policy written so it doesn't matter who the staff member is. There's a policy that someone has to follow. And then what is folks' access to gender affirming tools, especially when we're talking about mental health spaces, specifically inpatient mental health spaces. We want to make sure that all of our clients and patients have access to things like binders and packers and gaffs and breastplates and wigs and makeup. These are life-saving tools, and we need to make sure that this won't be taken away from someone in a time that they might need it most. If you're interested in learning more about policies, my go-to for pre-written policies and policies to kind of edit and change is creating equal access to quality healthcare for transgender patients, transgender affirming hospital policies. This was released in 2016 by Lambda Legal and the Human Rights Campaign, as well as the New York City Bar. Sometimes it can be really helpful when trying to work within your system and folks are saying, we need a rooming policy. And you're like, where do we start? Find the policies that have already been written that we know are trans affirming and then start to adapt them to fit your system. And y'all, here's one of my biggest pet peeves when it comes to, creating policy is we need to have it visible. Oftentimes hospital systems can create the policy, but then we'll keep it completely internal. And us trans and non-binary folks have no idea that there is something that is written that is protective of my existence within your system. So when you create these policies, we want to see it posted on your hospital website. I want to Google your healthcare site and say something like access to hormones at Colorado Health Network. And what comes up? I want to see that that is what I'm going to go through before I have to make a phone call, before I enter your system. We also want to see these in waiting rooms. We want to see these materials given when patients are registering in packets for new patients. We want to have all of these policies that impact our patient care listed, as well as we want these to be given to employees. So we want these in our employee work areas. These need to be frequently and routinely trained to not just all new staff who are coming on, but all staff who are interacting with patients in any way. And then again, we want to make sure that this is not just communicated to only staff or only patients, but across the board and throughout the communities that you're working with. And we'll talk about how we can get more feedback on some of those policies in a few slides. Oh, Ty and Misty, thank you for posting the link to the hospital policies packet. And then I see we had a question come in from Ash saying that their medical record has an organ inventory section. Could you share your thoughts on this aspect of data collection? I would love for other folks to chime in on this as we talk. What are your thoughts on organ inventory? I don't believe in organ inventory. I think it is a really great way to pinpoint trans people of just being about hormones and surgeries. And if you do an organ inventory in your system, you should be asking all patients and every patient's organ inventory. If you're only asking trans and non-binary people those questions, you're missing the mark here. We moved away from organ inventory a while ago, and what we did was we asked providers to ask questions when doing a general health history. So asking things like, have you had any major surgeries that might impact your care? Well, great, as a trans person, I could tell you that, like, yeah, a year ago I had major neck surgery, this is what that was. Or I could say, yeah, I had a hysterectomy back in 2019. But again, if you're asking about surgeries, we want to make sure that we're asking that when we're asking about general health, and we're asking that to all patients, not just trans or non-binary patients. All right, I see we had another question come in through the Q&A. Our EHR allows for name and does not require legal name. Unfortunately, sometimes our billing department, where did that one just go? Unfortunately, sometimes our billing department argues that legal name is necessary for insurance reasons. Could you speak to a way to work around that? Is that something others have encountered? So folks, let's write in. Have you encountered that your EHR doesn't need name, but your billing department for insurance purposes would need someone's legal name? Generally, what I have heard in the work that I have done is that let me rephrase that. What I have heard is, if health insurance has one name listed, we need to also have that name listed within a healthcare setting. So I can share an example. I go by Andrew. My name is Andrew Miller. My former legal name was Abigail Miller, and that's the name I went by. So before my name was legally changed, when I entered a healthcare system, though I only will respond to being called Andrew, that is the only acceptable name you could call me, when they run my bill, it does have to align with my health insurance, which has me listed as Abigail. And so if you are navigating health insurance, generally you do need to collect legal name. And again, if we do have to collect legal name, one of the things that you can do is talk with your patients. This is when legal name is going to appear, and this is when legal name isn't going to appear. And making sure you navigate within your EHR, having someone's name, the name that they go by, being the name, the main name that they use. I see we have folks writing in that folks are saying you have to use legal name to match what insurance has, or claims will not be paid. And we have another person saying that generally patient assistance programs do require legal name. So yeah, oftentimes we are going to have to look at legal name. We're going to collect that information, and we want to make sure that how we collect that and where we store that is affirming to someone, and we are not setting someone up or setting our staff up to continuously misname someone, which we know causes immense harm to trans and non-binary communities. All right, great questions, folks. Keep those coming. We have another person who just wrote in that says, yep, legal name is on all of our discharge summaries and sent to lab and billing. Another thing to note around kind of data collection and what that looks like is oftentimes you might have your nice, sweet EHR setup that says someone's name top and legal name bottom, but then when we do after visit summaries, it might have someone's legal name listed and then the name they go by in parentheses. That often happens in EHRs. And one of the things you can advocate for is moving that name, the name someone goes by, to be before the legal name. We want to set our staff up for success. And so if they're having to search around for what name to call someone, it is more likely they're going to misname someone. So we need to make sure that, again, that name someone is using, that affirming name, is listed clearly for staff. And we'll talk about that in a training section in a little bit. We have a few comments coming in, and that's so hard to navigate given the speed at which staff have to move at front desk. Absolutely. That is something that I work with our clerical staff on all the time, and all of our staff. When you're seeing back-to-back patients, if your EHR is set up to not assist in providing affirming care, it sets up staff to fail. And so again, we have to advocate and we have to write into our EHR companies and ask for these system changes and ask for these upgrades. And when possible, we have to put the finances of this forward. If I have the ability as a healthcare system to recognize that this EHR is not working and harming patients, we have to consider what that shift might look like. All right, and now let's jump into billing and insurance. Oh, I love these questions. Keep them coming, folks. So when we're building affirming systems, or when you're building out your affirming system, one of the things that I often see gets left out is billing and revenue. What I will say about this is, it was said yesterday, and I couldn't agree more, trans and non-binary bodies are constantly monetized within healthcare settings. Folks oftentimes will want to build out a program and the executive staff will agree with it because gender affirming surgeries could bring in money, hormones could bring in money, and that is harmful and dehumanizing. That's part one. Part two is, for our billing and insurance staff, we need to make sure we are providing the training so they can actually support and affirm trans and non-binary folks who are navigating the system. Billing and revenue teams need to create workflows that are unique to working with trans and non-binary folks. And it's important that these teams have knowledge around transgender and non-binary terminology and language, as well as transgender and non-binary care and how it applies. For example, it is quite common that for a transgender man or non-binary person who has a legal gender marker of male to be denied for a hysterectomy. Because again, when we look at what billing does, it's automatic coding that says hysterectomies are for people with legal gender markers of female. We know that's not true. And so again, if someone has a male marked as legal gender marker, that would be denied. And so we want to train our billing and revenue teams to catch that before that happens, to be able to recode it correctly so folks don't get denials. Or if folks are denied, that when they call billing and revenue, they will be called the right name, they will be called the right pronoun, they will not have to be the educator or teacher to another human, they will not have to put the emotional labor in, and our billing and revenue teams will catch that and make that shift. Another thing behind this is look at your payment plans. Undocumented and uninsured trans and non-binary people are dying trying to access care. And hospital systems and healthcare systems, the out-of-pocket cost it's out of control. And so again, it's really important that we are working, whether it is with community organizations, whether we are writing grants for this, or your system is building out its own payment plan. How are we getting folks connected to this life-saving care? And then lastly, what I want to talk about for this is, for insurance, trans and non-binary communities are constantly having to navigate complex insurance systems that leave us jumping through hoops to receive life-saving care. It's important that if your system is providing things like gender affirming surgeries or gender affirming medications like puberty blockers or hormone care, that your staff can actually help patients navigate the process of insurance. Generally, an insurance plan will have requirements for things like surgeries or hormone therapies, and sometimes those might align with your healthcare system, and sometimes they might not. And it's really important that you're able to make that distinction between the both of what is yours and what is the insurance company. If your hospital system has things like BMI requirements for gender affirming surgeries, we need to be advocating for shifts in this. We need to be advocating for informed consent on outcomes. If, on the other hand, it's an insurance requirement, then how can we be advocating at the state or national level to get these dropped, to make these focused on trans and non-binary bodies, not on what has been decided by generally cis providers and cis surgeons? So again, we want to make sure that these are clear. We want to make sure that we have staff who understand affirming care, understand insurance requirements, understand hospital requirements, and can walk side by side with our patients and with our community to make sure that folks can access this really important life-saving care. Sorry, just reading through. Oh, yep, I love what we just heard. How often folks will say, if we're doing payment plans, try to call it a charity case. And again, how dehumanizing is it that we have medical providers that are holding the things the trans and non-binary folks sometimes are waiting for their whole lives. But again, we use these terms like charity case when someone can't make means, when truly these services should be accessible and free for all folks in any country that they live in. We just live in a really messed up healthcare system right now. All right, and so then the next thing that I wanted to pull up was training. So, trainings. Y'all, we've talked about this and this has been brought up over and over again. Trainings, first of all, must be intersectional at their core. If they are not addressing racism and anti-racist practices, then they are not affirming. Systems of oppression are bound together, and far too often we'll address transphobia doing affirming care, but we will never address the layers of racism that Black and Brown communities continuously have to navigate. So when you are looking, and if you are a provider of LGBTQ trainings, if you are hiring folks in to do LGBTQ trainings, please make sure we're looking, what is the anti-racist practices that you are going over in this? How many points are you talking about the intersection of racism, of fat phobia, of language discrimination when we are talking about affirming and accessible care? The other thing about trainings, y'all, this needs to be done at every single level, at every hospital system. Oftentimes what I see is we will come in and your frontline staff or your primary care providers will have gone through like a trans 101, and one, that isn't enough, but two, that's not who necessarily needs the training. I want the executive staff to go through this training, or the president of your organization to go through this training. I want everyone from security to go through this training. We need to have it that from our environmental service staff to our emergency department surgeons, to our billing and revenue, to HR, every single person, patient facing or not, is actually receiving this care. Exactly, board of directors. It doesn't matter if you're going to build a system that can provide hormone therapy, if your system is not built on deconstructing racist, transphobic, and homophobic practices. And to do that, education needs to be given. This also needs to be continuous. Having one LGBTQ training that was done 5 years ago does not mean your system is affirming. This needs to be done in all new staff orientation. This needs to be done every year in annual education. And this then needs to be built to be department specific. One of my favorite things about my job is getting to do skill-based trainings. And y'all, trust me, it's hard in the state of COVID because we've gone virtual. This training alone is too much of me talking. I would love to be able to hear other voices. So when you have the opportunity, make them skill build and build the training based off of what that team does. Yes, there are certain things that are going to align. What I need HR to know and security to know and clerical staff to know and primary care providers to know, some of that might be similar, but there are certain things that are going to be unique to each department, and training should be tailored to each department. If your CNA staff is the people who are asking SOGI forms, so asking sexual orientation, asking gender identity, asking pronouns, we need to train them to do that, and then we need to have them practice doing that. If the only time folks are using things like pronouns or asking these questions are only to a trans or non-binary person, our community continues to be the educator and put that emotional labor on us. So again, when you are doing these trainings, make them interactive, make folks role play and practice the skills around this. And then lastly, evaluate it. We have said this earlier, we need to make sure that this information is done in medical schools, is done in medical systems, is done all through your program. And when we're talking about primary care providers or surgeons, there needs to actually be some evaluation and consequence to understanding language. So if a primary care provider sees the term transgender woman and can't figure out sex assigned at birth unless we have the term female to male there, that's absurd. Our healthcare providers are smart and can memorize so much information. We need to actually center learning trans and non-binary terminology, learning past trans and non-binary terminology, past the 101 to actually elevate this. I want you to know how to take care of my body without me spelling that out for you every way. And so again, what is the evaluation? We do skill requirement testing for healthcare providers throughout health systems. Why aren't we doing that around trans and non-binary healthcare? Why aren't we included with that? You would not let a medical provider come in and work at a hospital system if they don't know CPR, if they don't know how to read blood pressure. So why are we dropping the bar so low that trans and non-binary people have to explain the base language that we use? There needs to be evaluation and consequence that goes with trainings. All right, as you can tell, that's a soapbox for me. I'm very passionate about trainings. And then lastly, I just want to jump on a few things. I see these questions coming in and I'm going to move through this and then jump into those questions next, just so we can stick to time. Y'all, I actually hate the word safety. I think safety is a bogus term. What is safe for me as a cis-perceived white transmasculine person is not going to be the same for a Black and brown person, is not going to be the same for a non-binary person, also might not be the same for another cis-perceived white transmasculine person. Safety is a construct. And so we need to make sure that, again, we are not guaranteeing or saying that we are a safe space. That doesn't mean anything. What we can do is look at how are we being affirming or not. One of the things that I think can be helpful, and personally what I look for, is what are my visual cues before I even start interacting with a person. So when I go on your website, do you actually talk about trans and non-binary folks? Do you have policies that support me listed? When I walk into your space, do you have gender neutral restrooms? What does that look like? Do you have policies around that? What does your signs look like? I will share, y'all, I'm one that if we're having a gender neutral restroom, put gender neutral restroom or all gender restroom. Don't put one of those signs that has like an alien or a unicorn. Trans and non-binary people aren't mythical creatures, we're humans. And bathroom signs need to align with that. Other things is we want to see posters on the wall. We want to see what is your printed materials, your pamphlets. Do they actually align and affirm folks' identities? Oftentimes, to be honest, when I see printed materials, especially marketing materials for LGBTQ communities, it's generally white, cis-perceived, gay, thin men. Where is everyone else you're serving? So check your materials. Just because you throw a rainbow on it doesn't mean it's affirming. We need to make sure that your signs are actually, and your printed materials are speaking to the communities you are serving. And then things like the lanyards, the pronoun pins. We hear from our patients over and over again that this is something that when they see, there's this little like, okay, maybe this is going to be okay. Maybe you know what a pronoun is. And we want that. We want when folks see this to be able to be like, okay, like I might be okay here. That does not mean you're a safe person. Wearing a rainbow lanyard doesn't mean that you're an accomplice or an advocate. It doesn't. The actions that you take continuously every single day, especially on the times that your throat is on the line, that's what makes you an advocate. This is one part. This can be helpful. This is a great visual cue, but your actions have to constantly follow that up. And so I love these. Denver Health, we paint our sidewalks rainbow, and that's great. And that doesn't mean anything if our patients are consistently misnamed and misgendered over and over and over again. It's a slap in the face to trans and non-binary folks. So I ask folks, lean into that clinical environment, but make sure that you have the systems in place to support the communities you say you are welcoming to. And that goes the same for marketing. Y'all, again, oftentimes we'll see organizations will throw out really great examples of marketing and will put things like LGBTQ folks on a poster. But again, how are they actually supporting that? Do you have information that is really helping and supporting folks when they come in? If I see a sign that says provider of trans health and I call, are you going to ask me my name and pronouns? So again, make sure that this, again, trainings aren't just for our medical providers, they're also for your marketing teams as well. All right, and then the last section we have, system buy-in. So I see a few questions about this and we're gonna get into this afterwards. When we talk about system buy-in, there are so many angles we have to look at. For some of us, you are looking to build a whole new system or department in your team. For some of you, you already have a system that is going and you want to advance it. There are different things that come when we talk about system buy-in. And I think one of the most important lessons I've learned in doing work around building affirming systems is knowing your different why. The why that I use when speaking to executive leadership might be more based on quote unquote financial build or data from places like NIH. But when I'm talking to my medical providers, this is when I'm more focused on patient care. And this is when I might be more focused on what standard work would look like. But again, you need to have a breadth of data and know what is my why for the different folks who are involved in this. And then find your champion at every level. As a trans person in healthcare, I often have felt so alone in doing this work. And one of the things that has been really helpful is doing these system-wide reviews to figure out, okay, so what's currently happening? Who's currently taking care of trans and non-binary people in your system? What are they doing? Are they interested in helping you build this program? Look and find folks who are passionate about this, not just because there might be a personal identity involved, but folks who care about creating equitable and just systems. One of the other things I will say around this is also look at what programs you have. It is so big in healthcare right now to have DEI programs. Again, affirming care is diversity, equity, and inclusion. And so figure out who is doing this work and how can we pair with it together? Who is leading the DEI work in your hospital and how can we, again, make this work together? One of the other big things I've learned in larger healthcare systems is we love a good mission and vision statement. And so know your system-wide mission and vision statement. And so when you're making your ask or you're writing a proposal, loop in your mission and vision over and over again. How do these two things align? How does providing equitable and just affirming care fit the mission and vision of your program? And then again, we want to make sure we're aligning with any other strategic goals of the organization. For a system as big as Denver Health, this is hard sometimes. We have lots of employees all across the Denver metro area, and lots of folks are working on projects. So we want to identify who else is doing things around affirming care? Who else is doing DEI work? What does this look like? And again, how can we pair together? And then lastly, we got to look at what's currently going on. So I really recommend doing system needs assessments. So questions that could come in this, and this is your internal assessment, is how many providers do you have that are trained to prescribe PrEP or gender affirming hormone therapy? How many folks on your organization, if you provide gender affirming surgeries, have been trained to provide gender affirming surgeries? How many trainings have been done within your institutions? What policies do you currently have? When we are looking for that buy-in, first we want to know what is currently happening. What's your current state? And then from your current state, you can start to build out. All right, Ty, thank you for that reminder. I know I am at the end, and that is great because we will end on this one. Community buy-in. Affirming healthcare is nothing if it is not centered on trans and non-binary voices. Plain and simple. And anytime trans and non-binary voices are heard or used or asked, they need to be paid for. And I'm not saying $5. I'm saying let's recognize the cost of trans and non-binary lives and let's pay them a fair and livable wage to do this. When we are paying community, we also need to make sure that we are actually collecting information. So reaching out to the organizations that are currently serving trans and non-binary folks in your area, sending prospective patient feedback surveys, asking folks, what do you want in a healthcare system? What are you looking for? What are the things that might be helpful? Does your system need more help around housing or payment plans? Or do folks need more access to things like gender affirming surgeries? Ask what folks are looking for. Is there a boom of transgender and non-binary youth trying to access puberty blockers and the wait list in your area is 9 months long? Figure out what the need is, ask community and pay community for those asks. For your current patients, do patient satisfaction surveys. I cannot recommend enough actually creating feedback channels for patients to tell you their experiences. Asking things on these satisfaction surveys, not just name and pronouns, but if their health needs were taken care of. Asking things about not just trans health needs, but overall health needs. Figuring out what is working and what is not based off of your patients. And then y'all, if you don't have community advisory boards, I can't recommend them enough. And again, centering Black and brown, trans and non-binary voices within these community advisory boards and paying folks for your time. My other thing I will say about community advisory boards is don't make an advisory board just to say you have one. As you build advisory boards, make it very clear what feedback is needed and how to actually incorporate that feedback. Same again, make it very clear and put things on your website, on forums. If folks have complaints, if folks have feedbacks, who's the go-to person for that? If folks need resources, who's the go-to person for that? And then again, making sure that you're partnering with other organizations who are doing this care. It is so helpful to be able to know what is happening in the area around you. Who else is running into blocks based off certain insurances? What are some of the things that are going on that is working or not working? Again, we don't want to function in silo. We need to be expansive in that work. And for the sake of time, that is where I'm going to end it. And what we're going to do now is move into the Q&As, and I'm going to stop sharing my screen. What I will say as we talk a little bit about evaluation, and then I'll open those Q&As, is in the packet that will be sent out to you or is already available, I'm not sure, you will get it though. We built out a whole evaluation section in the end. So this goes through all of the different topics we talked about in great detail that lets you kind of give yourself a grade of what's working and what's not working. It then takes your staffing and goes through who are your key contacts? What responsibilities do you want for them? How does that work? And then it moves you into action planning for short-term and long-term goals. Building an affirming system can feel so overwhelming, and this packet is not, it is not the end all be all, but it's a small place to start. And so sometimes just having a chart that you can go over with your team can be super helpful with that. Y'all, it has been such a joy to be here with. Thank you all so much for spending this last hour with me and for all the incredible work that you are doing in your spaces and healthcare systems. Thank you.
Well, first off, let me just say, Andrew, it's always good seeing you. Thank you so much for the information that you've given us. If you enjoyed Andrew's presentation, please put your hearts and your hands in the chat box. And this is just a reminder that the systems in which we work in are so important when we're creating gender affirming care, and we have a person first and heart center approach. So next we do have a special treat. We actually have a special video from Rachel L. Levine. She's an admiral, and she served 17 years as an assistant secretary for the U.S. Department of Health and Human Services. And she's also the head of the U.S. Public Health Service Commission Corps. Hopefully I got that right. She fights every day to improve our health and the health and the well-being of all Americans. She's worked to help our nation overcome the COVID-19 pandemic and to build a stronger foundation for a healthier future one in which every American can attain their future health potential. Admiral Levine's storied career, first as a physician in academic medicine, and then focused on the intersection between mental and physical health, treating children, adolescents, and young adults. Then, as a Pennsylvania's physician general, and later on as Pennsylvania's Secretary of Health, she addressed COVID-19, the opioid crisis, behavioral health, and other public health challenges. So, without further ado, let's go ahead and play the video. I'm excited to watch.
Good afternoon. Thank you to the members of the Summit Planning Committee for inviting me to speak at this important event. I want to start by thanking everyone participating in this summit for your unwavering effort to serve, protect, engage, celebrate, and uplift transgender communities. This has been paramount in these uncertain times and remains essential to the health and well-being of communities across the nation. I commend and thank you for your continued resiliency, commitment, and passion for helping transgender individuals. The future is looking brighter than ever as we work to advocate and advance policies to ensure health equity for all. Now, it's been an exciting time for the LGBTQI+ community, and I hope that my appointment symbolizes progress. I am humbled to be the first openly transgender individual to serve in a United States Senate confirmed position, and the first Assistant Secretary for Health who is transgender. I am pleased to serve in this role for the impact that I can make and for the historic nature of what it symbolizes. May this appointment be the first of many like it as we create a more inclusive future. The administration is working to advance equity for communities who have been underserved by the federal government, and that includes my work at the Department of Health and Human Services. HHS values the health of all of us in the United States and is committed to ensuring that transgender and really all LGBTQI+ individuals have access to quality health care. At HHS, we are working to advance the Biden administration's commitment to strengthening access to high-quality, affordable health care across the country. We believe that our personnel, programming, and policies should all promote the dignity and rights of LGBTQI+ people. LGBTQI+ adolescents are especially at risk for being bullied, thinking about dying from suicide, and using illegal drugs. And we know that these risks increase significantly for transgender and gender expansive youth. School and family-based interventions can help reduce these behaviors and improve the health of LGBTQI+ adolescents. I would like to highlight the importance of diversity. Diversity for a school, health services, corporations, business, and government, and every organization. I strongly feel that diversity in all of its myriad and wonderful aspects should be welcomed and even celebrated for the way that it strengthens and enhances any organization. I encourage you all to emphasize and embrace diversity and inclusion. We know that there are many groups that face unique and increased risks. We must close disparities in access and outcomes, eliminate bias and discrimination, and address the systemic barriers, including systemic racism, that have contributed to historic inequities. Research clearly shows that transgender, non-binary, and gender non-conforming people disproportionately experience economic instability, poor health outcomes, violence, and discrimination. These experiences are often worse for transgender people of color, transgender immigrants, transgender people with disabilities, and others who hold multiple marginalized and intersecting identities. We hear you, we see you, and we are here to help. On May 10th, 2021, our Office for Civil Rights announced that it would interpret and enforce Section 1557 of the Affordable Care Act and Title IX's prohibition on sex discrimination to include discrimination on the basis of sexual orientation and gender identity. This means that if you believe that you were discriminated against in health programs or activities that receive financial assistance from HHS, you can file a complaint. OCR is open for business, investigating and, where appropriate, enforcing Section 1557 and Title IX cases involving discrimination on the basis of sexual orientation and gender identity in accordance with all applicable law. The steps we're taking at HHS to prevent discrimination against transgender Americans in healthcare settings is just one part of President Biden's executive order on preventing and combating discrimination on the basis of gender identity or sexual orientation. President Biden will champion full equality and civil rights protections for LGBTQI+ people to ensure that every American is treated with respect and dignity, regardless of their sexual orientation or gender identity. Everyone deserves to reach their full potential and, of course, access safe and respectful health care. We need to continue to strongly advocate for the most vulnerable across our nation and across the world. As a pediatrician and adolescent medicine specialist, I also know the importance of gender-affirming medical care for transgender individuals who need it. Gender-affirming care is both medically necessary and life-saving, especially for transgender youth. Unfortunately, some have sought to prevent transgender youth from accessing the health care that they need. This is political, and these politics have no place in our healthcare system, and they defy the standards of care. Above all, we need to support trans youth, their parents and families, and empower them to achieve the good healthcare and quality healthcare that they deserve. This includes LGBTQI+ youth, seniors, immigrants, and, as I mentioned, particularly LGBTQI+ individuals of color, such as trans individuals of color who are at risk not only of bullying or harassment or discrimination, but they are also at risk of violence and murder. COVID-19 has shown us that we are all in this together. We are all interconnected, and we have to get past our differences and prejudices that tend to keep us apart. I am a positive and optimistic person, and I think that the future is looking like a brighter, more inclusive place. Thank you.
Oh, let me unmute myself. I am thoroughly, that video is thoroughly powerful and it does show progress. And I'm very thankful, that she was able to give us a personal message. So as we know, whenever you're having fun, time goes by fast. And we're coming to the end of our day 2 of our summit. First off, let me take this time to thank our sponsors for contributing to our event. Thank you so much for all the speakers. Thank you to our fellow MC. I know Marissa wasn't able to stay, so much gratitude to her. Thank you for everyone for putting on the event. I'm going to go ahead and turn it over to Ty for his final remarks. And most importantly, thank you all for attending both sessions. Please remember to do your day 2 evaluations once this comes to an end. And again, much gratitude.
Thank you, Nevaeh. Thank you, Ty. Hello, everyone. My name is Zami Tinashe Hemingway, and I'm the CBIT Gender Affirming Project Manager with Denver Prevention Training Center and one of the committee members for this summit. I want to take this moment to say a few closing remarks. First, Admiral Dr. Levine recorded this video earlier prior to Governor Abbott's actions in Texas targeting transgender children and their parents. The actions of Governor Abbott reminds us how important it is to not just be advocates to transgender and non-binary folks, but be active accomplices with us so that people in positions of power are no longer able to abuse their power. Secondly, I want to thank all of you who attended today and yesterday. Many of you may not know this, but this is the first National Medical Mistrust Summit on transgender health, where every single plenary speaker, panelist, and facilitator is transgender or non-binary. And this is the first one where 99% of our subject matter experts are people of color. And like Admiral Levine said in her message to us, as well as many of our speakers the last 2 days have raised in their comments, transgender people of color experience the most health disparities and social determinants of health worldwide. So it is an honor and privilege to be a part of making history with all of you and elevating the voices of those most marginalized in our community. I also want to thank the plenary panelists today, Valerie Spencer, Cecilia Gentili, and Jenna Rapuez, as well as Andrew Miller and Fresh Lev White. Thank you to today's MCs, Marissa Miller and Nevaeh Anderson, for keeping us lifted and energized throughout today. And last but not least, I want to thank my fellow committee members. Before everyone leaves, there is a link to our evaluation in the chat box. Please complete the evaluation so that we know what you loved and ways we can improve programming in the future. You will also receive an email with the evaluation as well. So thank you.